Okay. We are recording. So let's talk about things. Tell me first about, what do you know about drug use? What do you know about a patient that presents with drug use?
Their
Like,
addiction.
as far as like their vitals or what?
There, now that I'm not muted anymore, sorry. All right, so tell me about a patient who comes in with drug use. What is their presentation? If it's a heavy presentation, if they're there, it's pretty serious. What do they look like? Tell me about what their mentality looks like based off of that. Are they sympathetic or are they parasympathetic? Get me in the right brain space.
Their appearance could be glassy-eyed, disabled. This They are erratic. They are sometimes combative or confrontational.
Okay. All right, now hold that thought for a second. How do they look? Paint that picture in my head.
Unkept.
Nervous?
Unkept, nervous. Love it, love it. Okay, what else?
Unclean.
Yeah, for sure. Okay, so probably dirty clothes. They might be tattered. They might have like really jacked up hair. They might be itchy, right? Because they probably don't shower so much. Perfect. All right, hold those thoughts. All right, do you see a picture in your head developing of who this person looks like? All right, so think of a tattered teenager. All right, now what is something that we can say that would help us get more information from them? How much trust is this person going to have with us? Not very much, probably, huh? Considering the aforementioned. So what is something that we can hone in on to ask them about the drug use so that we can gain that information and assess whether we need to do something for intervention immediately?
Can we ask them what they actually took?
Keep expanding on that. That's so good.
Any thoughts of harming themselves or others?
I love that, but that's for a later thought and that's for a different condition, but we are going to assess for that. Hang on to the idea of finding out what drugs they have in their system. So I like that idea. So what is something that we can relate to somebody else and make them feel comfortable sharing something that is that intimate?
Not creating a bond or a connection with them, making them feel comfortable.
Yes, yes. So what we do in this case is we simply say, hey, listen, I'm comfortable talking about use of street drugs. I know people who have used street drugs, right? So have you tried any of these street drugs? That goes a lot better than what drugs do you currently have in your system, right? Or the presumptive, right? Like you're all hopped up on Mountain Dew, so you just presume it's this. Both of those things are pretty negative connotations if you think about it. It's assuming without asking. We should never violate that space. We should always assume that what they say is how they feel. And the more that they trust us, the more they're going to be honest with us. And remember, the only rebellion left in this world is blatant honesty, good, bad, or indifferent. At least you know it's real, you know? So that would be my recommendation, is to understand specific to the scenario. We need to make sure that they understand, hey, have you tried any street drugs? I'm familiar with street drugs. I know teenagers who've tried them. What have you tried? That type of deal. Does that make sense?
Yes.
That was a lot of explanation for one question, but trust me when I say that all of those pieces of input are very valuable. All right. This is going to be super duper easy. Tell me about things related to mental health status that would let me know that someone is doing well.
I can't remember the exact name that it's called, but when they ask you, uh, do you have any thoughts of harming yourself? Do you feel safe at home? No.
That is actually a good point, because that is a different thing, but it is related to this actually. So you're talking about the items of a suicide assessment, and part of a suicide assessment is realizing, are they showing any significant signs of something being wrong? So let's first go over normal signs related to mental health status being good or bad. So what's something that a person can do that can affect what their mental health status looks like to me? If
Mood
they
swings.
slump over and they're like this, what is this called? Versus this, what's that called? What's this an idea of? This is
Depression.
posturing. Okay. We talked about the unkempt patient, the teenager, and we said that they were disheveled looking, they were tattered, their hair was unkept. Grooming. Does that make sense? How's everyone doing right now? Talk to me, friends. We doing okay?
Yeah, I'm
Yeah.
doing good. Sorry to hear the baby.
It's okay. It just when it goes silent, I go, uh-oh, is everyone okay right now? Let me do it. Let me do an air check real quick. Everyone good?
Yeah.
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 So let's go back to that idea. It's okay. We're gonna find our momentum in this. So when we're doing a mental health assessment, what are some things that we need to consider? I said,
If there are other people in the room, especially with like teenagers, they might not answer honestly if their parents are in there.
so what you're thinking of is an assessment on the patient as a head to toe. I'm talking about just a mental health assessment, assuming that everything in the room is okay. So what are some things I'm looking at just at the patient and that I'm assessing using a mental health assessment? So when I'm looking at the patient, what am I looking at to determine if this patient is having trouble? We talked about it earlier. Let's use the teenager.
Eyes.
Yeah,
Eye
eye contact.
Eye
Eye
contact.
contact. Yeah, now we're back on track.
If they're dressed appropriately.
It's perfect. Grooming, dressing.
How
Yeah.
they're responding to questions.
Yes, I think my problem was in my articulation. I think it skewed your interpretation. So I corrected the way I phrased my question, and you jump right on the band. Perfect. I realized that was my mistake. I apologize. So yes, posture, grooming, facial expressions, eye contact, orientation to everything around me. Am I bouncing around the walls and acting disheveled and crazy, or am I focusing on what you're doing? Right? That's the difference. So perfect. All right, we're back in line. I'm sorry. I got everyone confused. I knew something didn't feel right. I just couldn't quite figure out where we were at. All right, so let's jump back on track and do it well. So if we know that there is a patient that says something like, don't you just want to die sometimes? Or I just don't even know if I want to do this anymore. What's the immediate question I ask to clarify?
Are you having feelings of hurting yourself?
I love that. Why is that important? And why is that okay? More importantly, why is that okay? What's that a legal move?
Documentation. Letting
Document.
the doctor know.
Yeah, absolutely.
Just
More
screening.
Keeping
screening.
a close eye on them.
Yes. Bounce. Perfect. Also, in addition to those things, I need to know if they've developed a plan. I need to know what their plan of intent is, because the more developed their plan is, the closer they are, guys. Okay. So it's a conversation you need to have. And it's a very quick conversation and a to the point conversation, because remember, it only takes a couple of a couple of seconds to create a perfect sentence that is going to depict an entire picture. So you have to be very careful with your words, and whatever projection they're going to get off of those words are going to dictate if they're going to immediately trust you or not. So it's very important that we're to the point, we're clear and concise. And we simply say, do you have any thoughts of harming yourself? And that's okay, because in that instance, that is a reportable incident. We have to take immediate action. So it's okay to kind of be a little more aggressive and abrasive. Very good. All right, so let's talk about skin. Tell me, if I have a lesion, what is a lesion?
Like a cut?
I'll take that as gospel. Okay.
A
Specifically,
foreign object on your body.
go ahead.
Something foreign on your body.
I like that definition as well. I like the combination of those definitions with the word and or in there. Okay, good. So when I see a lesion and I call it an unusual lesion, ooh, tell me about that. What does it look like?
Could be raised.
Brown.
I love that. I love that.
Asymmetrical.
I love that. Oh, I love
Tabby.
it. I was going ding, ding. It's like, yes, yes.
Is it bigger? Is it the one that was bigger than 5 milliliters? Millimeters?
Millimeters. Yes. Yes. So here's what I've heard. I've heard poorly defined borders. I've heard asymmetry. I've heard appears different from others, AKA different colors. I've heard anything in excess of 5 millimeters. I've heard uneven color. All of those are appropriate and accurate. Is that understood?
Yes.
Cool. We're cranking along now. We got this figured out. Let me look at my notes. Also, let's consider depth and shape, although we did technically get those. And we got size as well. Okay, I think we covered all grounds. All right. Tell me about liver disease. Liver disease is seen in what type of patient? There's a chronic patient that's going to have liver disease eventually.
Cirrhosis.
Alcoholic.
There's one more. It's inadvertent.
A person with hepatitis.
Is it a person who took a certain medication for a long time?
Also, I love that. That's so smart. That's thinking way outside of the box. I love that. That was wonderful. Okay, good. So what do these guys look like, knowing all of those things?
Their skin is probably yellow.
It's called what?
Jaundice.
Now, y'all tell me y'all haven't learned nothing in this class. Have you heard how you're rattling this off? Are you guys not proud of yourselves? You should be very proud of yourselves. All right, so my friends that have helped out thus far, your job is I have officially silenced you. And now another set of comrades are going to come up and they are going to take the table. And now they're going to start rattling off answers. Cool.
Okay.
Proving yourself worthy. Thank you. You've done a good job. I'm so proud.
Molly, is there going to be questions about pressures, like the different, like, oh my God, I'm drawing a blank. Like for instance.
So I've got this perfectly lined out. I think I know what you're getting on that. And trust me when I say every bit of content we're going to go over today is going to be relevant to the exam, no more, no less. I'm not going to give you more than you can handle. Those items I put in our lectures that we have in class, or I throw those issues online so that you have enhanced learning. Anything we talk about in here is specific for those items on the examination. Remember, anything we talk about is up on the table. Cool.
Okay, thank you.
Yeah, no problem. I just don't want to push anything in there and give you unnecessary information unnecessarily. Does that make sense? I know how valuable your time is. I get that. Thank you. Okay, cool. I just want to make sure you're okay. I appreciate you. Don't forget to tell me how you feel because that helps me out. All right. Where else are we going to have this jaundice of our sclera? Where else is it going to be at?
Eyes.
Very good. Where else?
Hands.
And your nails.
Fingernails.
I love all of those. Specifically, if you were darker skinned, where is the best place to check?
Hands.
The palm. of your hand.
Fine.
Yes. High fives. All right, perfect. Perfect. All right, love that for you. So now let's move on down the road. Let's ease on down the road. All right. Haha. Now let's talk about cyanosis. All right. What is cyanosis?
Bluish tint of the skin.
Low oxygenation, pale.
I'll take both of those as gospel, married and combined and have a pretty little baby together. Anybody else? All right, perfect. I like all of those. Now, what is the presentation of a patient related to cyanosis? What do they look like? When I say presentation, I mean physically, visually, what do they look like from an aesthetic perspective?
Pale.
Pale,
Blue lips.
blue. Now, if I'm
Gray.
darker, am I blue?
No,
Blue,
If I'm
blue or
darker,
gray.
what color am I?
gray.
Ashen gray. Ashen gray. Perfect. Love that for you guys. Now, don't get that mistaken with a specific kind of spot. And what spot am I talking about? Anyone know? It's a bonus item.
Is it Mongolian?
Yes, Mongolian spots. Mongolian spots are different. That is not cyanosis. This is a issue with melanin being embedded down at the surface, at the bottom of the area of the tissue. Whereas most people, it goes to the top, right? So it's just an accumulation of that, which is that dark pigmentation at the bottom, which looks blue from the surface, right? That's different. Cyanosis is something that is an acute issue, or it could be a chronic issue. And it could be a result of things like COPD. That would be the chronic issue, right? And they would have the club fingers. Cool. So how do we check for cyanosis in a patient?
Pulse ox.
I love that. What's the way if we don't have anything on us?
Fingers,
What about the fingers? What am I doing?
fingernail,
Refill.
Oh, yeah.
Fingernail capillary refill. And what is considered cyanotic? Anything in excess of what?
3 seconds.
I love that for you. Good job. All of those things, perfection. All right. If I were to
baby,
tell you that on my skin, I notice.
babe.
Oh, everyone off on the mute button until we're ready to answer. There's some static. All right. So I'm looking at my skin and I notice that I've got little itty bitty dots of kind of purplish reddish. And they're just scattered about, like someone just got an ink pen and just dotted me up like a strawberry patch. What is this?
Petechiae.
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 Close. I'm looking for
Purpura.
a word. So it is petechiae, but there is a word for the color that it creates. And what is the word? It's that purplish reddish color known as.
Is it purpura?
It is. It's purpura. Good. Or purpura. Good. Perfect. I just need for you to make the connection in all of those. Now, bonus points. What condition or what medication would cause you to have purpura? What causes the little patchy dots? What is that truly?
Like a blood thinner? Is it blood thinner that does it?
Broken blood vessels.
So it's a blood thinner. Specifically, anyone know what blood thinner?
Or Levonox would do that?
Warfarin.
Luminine,
Warfarin.
Eliquis.
Penicillin? No.
My cup runneth over with joy. Yes. Okay, good. So what would be a medical condition a person would have, that would cause purpura potentially?
Hemophilia?
Hemophilia. Yes. Okay, good. That's exciting.
What-
I'm excited.
Professor Molly,
Yeah, go.
what was the answer? What med would cause purpura? Was it heparin or?
So the answer, believe it or not, is kind of all the above. So Lovenox is one of them. That's usually a subcutaneous injection. We use those when we're bridging people over to Coumadin, which is going to be another good blood thinner. That is a true blood thinner, right? And then we also have, things like aspirin, which increase risk of bleeding. And then we have things like ibuprofen that do that as well. There's a lot of medications that are involved. I just want you to get your brain in the right space. That blood thinners equal bleeding, equal purpura, equals medical condition where you bleed. So purpura and bleeding, perfect.
Thank you.
Uh-huh. That's a perfect connect that I need for you to make. You're going to need to know that for your other med-surg classes, because we talk about things like platelets, and we talk about heparin drips and things of that nature. So purpura is going to be known for thinning agent. Okay. Or things like cancer and such, because we're killing, the ability for those cells to be stable. All right. So when I'm looking at a person's, let's move on to nails. When I'm looking at a person's nails, what do I expect to see? What is a normal finding? Tell me what that looks like first.
Can you ask that again, please?
Yeah, when I'm inspecting a nail and assessing a nail to see if my patient has trouble, what am I looking for when I see it? What is normal?
No white spots.
The grooves in the nails.
Are there grooves in the nails?
Yes. Well, no.
Rounded and 160.
Rounded
should be-
and
160.
it is blank sailing.
Smooth.
Yes.
Yes.
Our expectation is smooth and rounded. Our expectation is slightly pink. Now that we know what the normal looks like, tell me about what would be an abnormal finding, and then tell me what the disease process is of that abnormal finding.
Black nails.
Mean?
Cancer, chemo.
Okay, also it could mean what? Depending on if it's black and blue.
Oh,
poor
poor circulation.
Or potential trauma. But what would also happen to a nail if it was true trauma?
It will fall off.
Like a clot, a blood blister. Or something.
That's also correct. Yeah, you could put that blood blister in there, right? You can have it's like a little tiny hemorrhage in there that could also cause a discoloration. So you need to know the difference in the two. But we made it perfectly clear what cancer looks like versus what a blood trauma would look like. As well, that nail would be pressed, and would I have any type of trauma lines in there?
Yes.
Yeah.
You would have some trauma lines in there. We'll get into that in just a second. Okay. So let's get off the nails for a second. I feel like we covered that. We'll come back to it. So let's talk about assessment of the face. If I were a 58-year-old man, what would be a normal finding of the aging process in a 58, 59, 60, 70-year-old man?
You asked normal.
Mhm.
Maybe balding, wrinkling, like droopiness on the face a little bit.
All of those. I love all of those. I don't feel like
White facial hair.
well, oh yeah, loss of facial hair, aka baldness, right? I'm gonna expect wrinkles. I'm gonna expect little spots, right? Because it's going to be the progression of that tissue, especially if they're farmer. I'm going to look out for abnormalities behind the ears, around the nose area. That's a given, right? Because what do farmers do?
They're in the
They're in the sun. And what do we know about male farmers who work 7 days a week? They probably don't take time to go to CVS to go get sunscreen. So we have to check those spots and be aware that those might create those lesions that we were talking about earlier. Okay, good. We're doing really good. My favorite subject. Not. Tell me about, let's go to neurology. Tell me about migraines.
They can be debilitating.
Sure. Okay. So tell me, what are my signs and symptoms?
Blurred
Severe
vision.
headache.
Pain. You can be sensitive to light and sounds.
So far,
Vomiting.
okay. So far, I've heard nausea, vomiting, photophobia, headache,
Hypertension.
okay. All those cover it well. What do I need that can take care of some of that immediate pain?
Sleep.
Sleeping, resting, lights off. What else?
Cool room.
Cool room, cold compress. Think cold, think quiet, think dark. Perfect. I love that. Now, how is that different from a cluster headache?
That hones into one spot.
Okay. Okay. What's the difference in pain variation? Tell me about the difference between migraine pain versus cluster headache pain.
Is
Sharp and intense.
Sharp and intense is going to be our cluster, because the word cluster implies I'm packing things together and I'm smacking it at you acutely, versus chronic, which is I'm used to dealing with angry, annoying pain, but I'm just kind of kicking it. Does that make sense?
Yes.
Cool. All right. Let's move over to sinus cavities. Tell me what is wrong. Actually, let's back up. Where am I at? Let me see. Cool. Tell me about sinus headache. So we're still talking about headaches, but we're going into sinus. So tell me about a sinus headache and what's different about that.
A lot of face pressure.
A lot of pressure. I love that. Keep going.
It's usually right behind the eyes.
Behind the eyes. Yeah, for sure. For sure. Yeah. What else?
Would a sinus headache be like seasonal?
It is seasonal, which means my drainage is what?
Um,
Come on, get dirty with it. Get nasty.
I'm thinking. I just got off 13-hour shift. I'm thinking.
Go. Awesome. Work. Literally.
Is it green, yellow?
What did I hear? Green?
Green. Yes.
Oh, it ain't easy being green, but in this case, it is. Okay, because it's greenish yellow. Perfect. All right. So, what are the expected findings of this patient?
Congestion, puffiness in the face.
Come on. How much
Post-nasal drip.
pain? It hurts. You ever had that? And then you try to blow your nose, but it doesn't go anywhere. And there's like no transfer and it makes that weird, like dense sound. And then you have an incredible blinding pain right here. Nobody? Just me? Come on. Nothing? Okay, it's the thing. It's awful. It's not fun. Okay. So I love that for you. So yeah, green, yellow drainage when we're dealing with sinus headaches, that's a specific piece of it, as well as the presentation of puffiness, fullness, the feeling of fullness, and pain, tenderness upon touching. Very good. Ooh, we're going to get cranial nerves. You ready? Girl, don't you me. Cranial nerve 7. Cranial nerve 7. What is it?
Is that the facial nerve?
Yes. All right, cool. How do I check the facial test for cranial nerve 7, facial cranial nerve? I think I said that. Yeah.
Yeah. Smile.
Smile. And I'm smiling and I'm checking what? And I'm doing this thing, not to be funny, haha, but I'm doing it because I'm splitting my face in half because I'm checking for
Symmetry. Face symmetry.
good. Very good. Now, bonus question. If I have asymmetry of the left side of the face, where is my stroke?
The right side. The right side.
Right side.
I'm so proud. This is Med-Surg 2-level information. And you guys are just killing it. I like this. Do we like this picture-in-picture business? Is this helping you? Do we like
Yes.
it, or is it annoying? I don't know what to do with this yet.
Keep it.
You know, I always pause for the cause. Like I have to do a democracy, right? This is King Arthur and the round table, right? We're all equal. So you got to tell me and I got to figure this out. So if this is working, cool, let's just keep doing it. I'm down. All right. So we're looking for symmetry when we're dealing with that specifically. I love that for you guys. Ooh. Movements of the eyes. Tell me the cranial nerve.
Is that 3?
It's three.
Oculomotor.
Trochlea.
Ooh, that's interesting. Okay.
Oculomotor, trochlea, and
How about this? I've
abducer.
already heard 2 of the 3 answers because technically that's accurate. So what is the test?
People's response to light.
So you're 2 is about light and accommodation.
Yeah.
3
And
ocular,
the
motor
gaze
movement.
The
I'm driving car.
peripheral and the central gaze.
The 6 cardinal positions of gaze.
Yeah. Yeah, that's the answer. It's the cardinal, it's the cardinal field of gaze, okay? Because remember, ocular, eyes, motor, and in that steering wheel, if you look at it when you wake up in the morning, it should go into a dip of 3 when you have that. So it's easy, ocular, motor, cranial nerve number 3 versus I have 2 eyes. My eyes are meant to see. Cranial nerve 2 is optic. Does that help?
So the answer is 2 and 3?
No. So the answer is actually technically from that variance 3, 4, and 6. But in this specific case, I just need for you to understand that when we're dealing with movements of the eye, because it's several cranial nerves, movements of the eye is going to be a reference point to the test of the cardinal field of gaze test. Does that make sense? Whereas if we're doing cranial nerve 2, our optic, we're going to use the Snellen test. Does that make sense? One's visual acuity and one's movement of the eye.
Okay.
One's checking on laser focus and one's checking on your ability to use that laser focus and move it about.
So we're not using a particular number.
Not for this one. But you need to know that because it could be, depending on what the test is, 3, 4, or 6. Because those are all dealing with movement. Does that help?
Yes.
Remember, I said bonus question because I was awful curious who knew that. So that was a bonus question, as in bonus questions are not a part of your examination this time, but maybe next time. So that's why you need to know it for next time. All right, so going back, just to make sure that we understood, a Snellen chart is used to test what cranial nerve?
2.
And what's the name of it?
Optic.
Very good. Both of those are very good. Now let's talk about hearing tests. What do I need to do during a hearing test?
Talk.
All right. What do we test is it? What kind of test?
The patient has to cover one of the ear, and the nurse, you don't have to stand behind the patient. You stand close to the patient and you say a word to the patient, and the patient should repeat whatever you said back.
Beautiful. So why do we not stand behind them? Well, your ears are facing this way. And if my ears are facing this way, they don't face that way. So standing behind them is actually a disadvantage because it has to wrap all the way around. All right. So you stand in front of them and someone goes, oh, well, if you stand in front of them, then they can just read your lips. All right. Guess what, genius? You have a phone. You can put it right here and you can't hear what I'm saying, or you can't see what I'm saying, but you can hear it. Just put something in front of your face and then go 55. All right. Perfect. That's exactly what you do. I love all of those answers. That was fantastic. Okay. We're making good time. Let's make it a little bit faster though. All right, cool. In the mucous membranes, inside, what filters the air that makes it easier to breathe through your nose than it is your mouth? They're little conch shells. They have names.
The cilia or the
Cilia.
Cochlear.
This is in your ear. I'm talking about your nose.
the hair.
Mucus membrane?
It was the word that I used. It was a weird word, and I said it over and over and over because it was just a funny word. If I slice my nose off, they will be in weird little curly cues on either side, and its job is to help send the air through, and as it's spinning, it's filtering at the same time. They're pink.
Flagella?
I was going to say, but I'm like, nah.
Y'all are going microbiome on me over there.
I know, right?
Nostril. Cilia? What is happening? No. Oh, pink turbinates.
The contract.
I wouldn't have got it.
I wasn't getting that one.
It's cool.
Me either.
It was somewhere in the middle. I mentioned that. I mentioned it all but briefly. And its purpose is, the concept I need for you to understand is when you breathe through your nose, is it a more effective breath?
Yes.
Yes.
No.
Is that a more effective breath? Which one is more effective for oxygenation overall?
The mouth.
Oh, is it the nose?
I want you to try to expand your lungs, breathing out with your mouth and then breathing in with only your mouth, no nose. Hold your nose and do it. I challenge.
I guess it makes sense if you're sleeping, your mouth is closed, so it would be your nose. It would make sense.
So close your nose, breathe out, breathe in, open your nose, breathe in through your nose and out through your nose. Feel the difference. Feel the difference in your lung expansion.
So
Well,
how does that work with?
when you're
What's that?
oh, go. I
So
said
how does
when
that
you-
work with? Oh, I'm sorry.
Go ahead, you go.
So how does that work with people with like sleep apnea?
So we'll talk about sleep apnea for next exam. I don't want to use this forum to talk about that because this next exam, that is going to be a big discussion because we talk a lot about cardiac. Remember, next exam is all about cardiac. So I've thrown a lot of cardiac out there. There's a cardiac lecture on YouTube, and I talk specifically about those masks. It's in the very long lecture. It's about midway through. I'm thinking slide 86. There was 202 slides in that lecture. It was a long day yesterday, but we got through it and we did it. All right, so let's keep going. I didn't mean to put a pin in it, but I need to put a pin in it because I'm trying to respect everybody wanting to go to bed. And I have to make up for my PM class not being there. So I got to figure out what I'm going to do about that. Plus I got a speech I have to figure out that's tomorrow for a pinning, which is a big deal. So there's that. Sorry, digressing. I'm trying to remind myself of what I have to do.
So the answer to that was the nasal concha, or is that the turbinates?
They were the turbinates. They're right. The turbinates are basically around that area, and that's what helps filter the air and get the bigger breath. There's a lot of pathophysiology, but basically that's it.
Okay.
Let me clarify because I think I might have confused you as well. Pupillary constriction to light. So we're opening and closing, right? Is that 2 or 3? Is that cranial nerve 2 optic or cranial nerve 3 ocular motor?
3.
3.
You know, it's 3 because I'm z and I'm z. All right, perfect. Now, again, going back to eye movements, all right? When we're talking about eye movements, what are the 3 cranial nerves that I mentioned that are all respectfully a part of this movement, this eye movement? Give me the cranial nerves.
3, 4,
Two,
and
3, 4.
4 and 6.
3, 4, and 6.
3, 4, and 6. And I know that you guys know the names of it, but for the purposes of everyone cramming together, I'll go ahead and tell you. 3 is ocular motor. 4 is abducens. And what's 6?
Trochlea.
Whatever.
Questions? All right. How do I remember 4 and abducens? All right. Here's how I remember that. You ready for this? This is going to go real weird, real quick. But abducens is a weird word. And I found a way to get it. You ready? All right. Abducens sounds to me like the word ab, like abdominals. Do, as in them abs do make sense, as in you got a nice pack of abs. Abducens, and then think cents like money, 50 cents. Because in the very beginning of the Find Me in the Club video, he is upside down with them 4-pack of abs, and he's going, "Go Shardy, it's your birthday," and he's doing this business right here, right? Abducens. Does that help? It's a stretch. It's weird. It works for me.
That helps a lot. That's
That
funny.
analogy.
The ab part
It's a
definitely
stretch.
works.
It just hit me, but it works perfect, and I can appropriate it. Is that cool for you guys? Because it's a weird word. How else is anybody else going to get that? Are we cool with that? And I painted a picture, right? Because the song is done. Dun,
Yes, you clearly painted a picture.
dun, 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 go, go, right? So it's in your head. You can't lose it now. Good. Are we cool with that? I might actually do a short on that because that's actually pretty smart. I like that. Somebody text that to me. Type in cranial nerve 4, 50 cents, and that'll be good enough for me. All right. So isn't this fun? See how we can just make it fun? We can come up with ideas like on the fly. I love how we do that together. All right. So let's talk about pressure injuries. Aha, here we go. All right. I'm going to give you a description and you tell me what stage. Whoever.
Well, hold on. Did we talk about 6 yet? Isn't abducens 4?
Did I do that backwards? No. Right. This is the 4-pack.
Yeah. So what about 6?
6 is trochlear. Yes.
Yeah, we didn't talk about that one.
My brain is in 15 different directions. Help me get my brain right. Okay. Because I'm working on trying to do a thing for Christmas for you guys too. So I'm texting, I'm going over my notes, I'm recording a lecture technically, and I'm talking to students. So help me figure out where we're at. Okay. So 3, 4, and 6. We said ocular motor. We got that straight now. Yes.
Mm-hmm.
Okay. 4 is what nerve?
Abducens.
Okay, we talked about that. And then you're asking for a hack for 6, correct?
Yes.
I think they're mixed up. I think that
No, 4
ab-
is
That's
and
wrong. 6
4
is
is
abducens. 4 is trochlear.
yes.
Okay, that's why I'm looking all weird. I said that backwards. I apologize. Let me clarify. 50 Cent has a 6-pack of abs. Okay.
Okay, because I thought that's what you said in the beginning, but I'm
I
like,
thought I made that clear, but I might have said 4 because remember I'm doing 15 things at once, which isn't fair. But unfortunately, when I got all this happening, I don't have a choice. So I'm going to do it because I'm not going to let anybody down. All right. So I might slip a little bit, but we corrected it and we're good. Does everybody understand that? 3 is ocular motor. 4 is not abducens, it's trochlear. And 6 is abducens. And we say 6 is abducens because 50 cents has a 6-pack of abs. Abducens 6. Make sense?
Yes.
Yes.
Oh, that makes way, way more sense because I'm just being real. It is what it is. All right, cool. Can we move on? Are we good? Do we feel comfortable?
Yes.
All right. Pressure injuries. Talk to me. I'm going to give you a descriptor. You tell me the injury. All right. Y'all are blown up the phone. I don't know what's going on, but I'm about to check. All right. Okay. Pressure injury. Non-blanchable redness. Located over the bony prominence. What's
1?
Is everybody cool with 1? Does anyone have any other objections?
No.
what did you say? Because I didn't hear you. What happened?
Okay. 1, pressure injury, non-blanchable redness
Okay.
located over the bony prominence.
Okay.
What stage?
1.
Okay, cool. That is accurate. Now, tell me the same characteristics of a stage 4.
You can see the bone? It's open?
It's
Is it
well,
partial thickness, full thickness?
Full thickness.
Full thickness loss. You said exposed bone?
Yes.
Good. What about tendon? What about muscle? Are those included in that?
yes. Yeah.
Nice, nice, nice. What is our biggest concern related to that stage 4?
Infection.
Damn it.
And then what happens in the big baddie when we get a stage 4 and
Gotta cut it off.
infection, where does it go?
To the bloodstream.
It causes
Sepsis.
Septic.
perfect. Perfect, perfect. Could not be more proud. Thank you so much. You guys are doing a fantastic job. All right, you ready for another one? Full thickness skin loss, damage, necrosis of the subcutaneous tissue.
Unstageable?
3.
3.
A 3?
Is it a 3? Is it unstageable? Let me do it one more time. You ready? Slow down. Full thickness tissue loss. Oh, yep, there we go. Full thickness tissue loss. Okay. If we have subcutaneous necrosis.
It's unstageable.
Unstageable.
What was my trigger word?
Necrotic. The necrosis.
Necrosis, necro death. Perfect. If I can't see it, I can't confirm that that's death up under it. Therefore, it needs to be what?
Clear.
Debrided.
Debrided before I can do anything and stage anything. I love that for you guys. It's so good. So what do we have to worry about when we're talking about unstageables or any pressure area for that matter? One of our concerns is the idea of
Tunneling.
tunneling. I love that for you. Good. Perfect. And we have to debride to do that. Okay, here's another one. This is probably the hardest one. All right. Full thickness skin loss. And in addition to that, the base is covered by yellow sloth and tan eschar.
3? Would it be still unstageable? Or
4.
Can you repeat that again?
Of course. All right. So, pressure injury, full thickness tissue loss, base is covered by yellow sloth and tan eschar.
Stage 2?
Mm-mm.
No.
is it
I think
unstageable?
stage 3.
It is unstageable.
It still has that slough and all of that stuff over it.
Thank you.
Okay.
Thank you. Thank you. Good job. I'm looking to see if there's anything else I would miss in between. Okay. Now, if I had tissue loss of the subcutaneous tissue with small parts of necrosis, this is the only weird situation. So in this case, it would be, I would have full loss of tissue. I would have necrosis to subcutaneous area. What is that technically?
It's under, so is it like the stage 2 maybe? No, it's still unstageable, or I don't know.
Any other thoughts from anybody? What do you think? Let me read it one more time very slowly. Full thickness skin loss involving damage to or necrosis of subcutaneous tissue.
Be 2.
No,
Unstable.
no, it's 4. Is it 4? Okay, look. Oh Lord.
How about I explain that one in class? I will go over that one again. Okay. But just know that there's technically, because of the wording of the question, I already see a problem based off of how you're answering me. And I think I'm going to have to fight that question potentially, which is good because I think I might get those points back. And I think we might be able to apply that back. I'm not entirely sure, but looking at it and hearing what you already have to say, I could see it's going to trend in that direction. And I don't want to get into it any further without revealing anything, but I think I might be onto something. So don't worry about that. I'll explain again to see if I can clarify a little bit easier. All right. If I have fingers that are clubbing, what is that an indicator of?
COPD.
Boy, you just went there, didn't you? You didn't waste no time, did you? You just kick it on home. All right, cool. And what is this condition called where my fingers are clubbed? What is that a result of? Chronic what? It's chronic COPD, but what's the problem with the fingers specifically?
Losing oxygen.
Also known as chronic
Hypoxia.
chronic hypoxemia. All right, good. Are you ready for sounds, for lung sounds? Are we ready to do this? Okay. Lung sounds. High pitched, high frequency, aerated, inspiratory, and expiratory. What is my disease? Or what is my sound?
Wheezing.
Perfect. What is my condition?
Asthma.
And what do we do to fix it? That's our bonus question. What's our medication?
Albuterol.
That's med surge too, guys.
Okay. What was the lung sound again?
What was the lung sound again, friends? High pitched, high
It's got
frequency.
wheezing.
Wheezing. Okay, I didn't hear him. Okay.
You're okay. Wheezing condition is asthma. Albuterol is
Albuterol.
management. What's our side effects of albuterol? We're going to get super stupid. We're going to go exit Hesse. Let's go all the way to the top. My little class is just starting off your first nursing class. Come on, give it to me.
Elevated heart rate and bitterness.
I'm sorry. What was it again?
Shaky.
Shaking, hyper, and tachycardia. I love those for you. Good job, guys. Killing it. And we got visual evidence of this awesomeness. All right, so let's do another sound. You guys are on a roll. Ooh, low-pitched, coarse, snoring sounds during inhalation.
Strider.
Not quite.
Ronchi. Oh, Ronchi.
All right, I'm going to do Strider for you one time, and it's going to make me cough, and I'm going to do it recorded, and this is going to be super embarrassing. You ready? You're never going to forget the sound. This is exactly what it sounds like. You ready for Strider? It's awful. Here it goes. Sometimes it's even higher. Sometimes it's more of a wheezy, but the stays. So sometimes it even goes. I'm going to try it one time, and I'm going to cough like a crazy person. That's it. That's the sound. It's in between breaths. And it happens every time. Because in order to do that, do you see how jarring it was for me? That was just to simulate it. That's not to actually act upon it and go through the sympathetic nervous system process of a panic attack while you're going through it. Can you imagine? So this is why we need to move so fast. I hope that helped paint a bigger picture, you know? All right, so while we're on the subject of Strider, what's the presentation of Strider besides really crazy sound?
Retracting.
Say one more time, skeletal.
Retracting.
Retracting. Skeletal retractions? Is that what you meant?
Yes, like stomach breathing.
Yeah, and those little muscles in between will be popping out like this. It'll literally, every breath, they do this in between the ribs. You'll see them. All right, keep going. They're called accessory muscles.
Kind of scratchy.
That scratchy, wheezy. Yeah, what's the problem? There's no air exchange, right? I'm trying to suck in, but it's closed off. So I'm literally sucking in this bit of air and that's it. And I'm just rolling off of that bit right there. So that's why I'm going through this attack. It's because it's like trying to breathe through a coffee stirrer straw from McDonald's circa 1992, which most of you guys don't even know what that's like. It was red. It had a white line in it. People used it for the wrong reasons. They took it away. I was really upset about it. Okay. This would have been perfect for that demonstration. It feels nearly impossible. All right. And finally, sorry, that was a lot to unpack in 1 second. Finally, this is a result of a chronic condition that is progressive, related to both heart and lungs. This sounds like low-pitched, bubbly, watery sound. Crackles. Give me the condition.
Pneumonia.
CHF.
I'll take that, but I'm looking for the bigger one.
CHF.
CHF. Here we go. Bonus. Left or right sided?
Left.
Left sided.
And bigger bonus, medication to fix it.
Furosemide.
Furosemide, also known as?
Lasix.
Lasix.
God, how far can I keep going? Let's do this. What's the problem with Lasix?
You lose potassium.
If I push it too fast, what happens to me?
Autotoxic. You die.
You don't die, but you do go ototoxic. And what is ototoxicity?
Loss of ears.
Ringing in the ear.
Loss of hearing.
What do we need to monitor on this patient?
It's about weight, but it's else with weight. It's
What about weight?
It's something
Eyes and nose.
Oh yeah, eyes and nose, yeah.
How much of a differentiation of weight do I need to be concerned with over a 24-hour period?
3 pounds to 5 pounds.
I have this recorded. Guys, jokes aside, I like you guys are just, you're pumping me up, man. You're making all of this hard work that I've been doing and all of these hours so daggone worth it, because you're sucking it up like a sponge and there's just room for more. And I'm telling you, this cohort is special and I'm so grateful. Thank you. Now let's regroup. All right. I'm a patient. I have nasal flaring. I'm all of a sudden restless. I have those skeletal retractions we just talked about, those accessory muscle uses. How would you interpret that presentation of a patient?
Difficulty breathing.
Signs of difficulty breathing, aka known as what?
Impaired respiratory exchange or air exchange.
I'll take all of those as gospel. We call it respiratory distress. That's your tagline. That's a sign of respiratory distress. What do we need to do with these patients?
Monitor them.
What is my
Get them some oxygen.
What's the first thing I'm doing?
Give them some oxygen.
Sit them up in bed.
But before that, I need to know what?
What's their oxygen level?
Their oxygen saturation. I'm throwing a finger probe on. If you can look at a person and see that they have all of those things going on, you know that they're respiratory depressed. What you need to find out is if they're getting oxygenation or if there's something occluding it and there's going to be no way for them to get any oxygen. Because if I have something in the way of my trachea and I shove oxygen down it, it simply goes through my nose and directly out of my mouth. Does that make sense? So how you can test that is if their mouth is shut and you have oxygen on them, their cheeks will puff up like a chipmunk, and then they'll eventually go and they'll blow it out. So then you physically close it like a button and watch, and you'll know because you will feel it up under their nose escaping out of their nose. Right? It's because nursing is what? It's common sense. It's just like checking to see if there's an air leak in anything, right? Same concept. Just like an air leak in a tire. It really is that simple. Now, let's talk about other sounds. And in this sound, it's more about a pattern. It's a weird respiratory pattern. So I have variations of periods of increasing depth followed by a moment of apnea. So let me demonstrate. It goes.
Is that chain strokes or something? What's that one?
Cheyenne Stokes.
Yeah, Cheyenne strokes. Yeah.
Here's how I do it. Cheyenne Stokes has weird breathing strokes. Is all I got. Anybody else? God, these weird lung things you guys are making me do. Who needs an incentive spirometer when you got this class? All right. So what do you think? Is there a better way of putting it, or do you think that that's good enough for right now? Because it's all I got, but it rhymes and it works. Maybe.
Yes, honey.
Get something better. Let me know.
For Veterans Day.
All right. So now let's talk about problems with cardiac patterns. So recall, what is a normal heart rate?
70 to 100.
60 to 100.
Yeah.
Cool. So anything in excess of 100 is called
Tachycardia.
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 anything below or the line of 60 is
Bradycardia.
very good. Very good.
Do you work tomorrow? No, but I got school.
I definitely work all day tomorrow, and I got school, and I got speech. I'm nervous about that. Hope I don't screw the pooch. It's gonna be fun. Also recall in crackling, there's also a potential for popping noises as it's described, because that is a potentiation of bubbling. Tell me normal breaths. How many per minute?
12 to 20.
16.
Well,
Oh,
20 is the answer. If I have a respiration rate of 28, what would that be called?
Tachypnea.
Tachypnea.
Tachypnea is good. We also call it simply tachypnea. That's what it actually sounds like, tachypnea. Although people do call it tachypnea, so that's why I don't bother with it. But it's tachypnea. Good. Tell me how you're supposed to properly listen to a person if I'm assessing the lungs, the heart, the abdomen.
Supposed to watch how the chest rises and falls.
Where is my stethoscope located?
The apical.
Let's say anywhere on the torso. Where's my stethoscope located?
The herbs point.
Anywhere in the abdomen, the trunk, it doesn't matter. Anytime you're assessing from here to here, where do we need to make sure that stethoscope is located?
The apical pulse.
So we're not assessing heart. Let me see if I can reappropriate this. I'm not asking right. Ah, okay. I am assessing either the abdomen, the heart, or the lungs. I need to make sure that my stethoscope is placed not on the blank, but on the blank.
On the skin.
Not on the shirt or sweatshirt clothes, but on the skin. Very good. I was doing that wrong. I figured out what worked best for you. I'm really grateful that we were able to communicate that, because that was going to get really sticky and it was unnecessary. So I'm glad you guys made it easier for me. All right. Tell me about bronchovesicular lung sounds. Where are they located? What are they?
Are they located in the bases?
I will take that. I will take that, and I will. That is a correct answer. That is technically a correct answer. So they're normally heard over the central area of the anterior versus posterior, thorax, right? And are they normal or not?
Not.
You said they're not?
They are.
They are. So remember, this is where you have a person who has had an upper respiratory infection or a chronic lower respiratory infection sometimes. They are heard over the trachea sometimes. These are sounds that are resulting from its position or its change in tissue shape based off of, potential for scarring from like chronic bronchitis as a kid or something like that, or seasonal allergies or things of that nature. It is positional change in sound, but isn't necessarily a bad thing. It's just a change in your baseline. Does that make sense? So know that they're normal. Know that they're heard mostly between the lower lobes of the apex area of the thorax. Know that they're okay and they're benign and non-incidental. All right. So let's see. We're nearly done. Do we want to keep just going through it? Just keep rolling. All right, rolling. Tell me about deep tendon reflexes. What do we know about deep tendon reflexes? It's graded. We know that. Deep implies deep. Tendon reflexes. If I have excitability of tendons, okay, and they go all the way that deep and they reflex, what is that? What kind of response is that? Is that hyporeflexive, hyperreflexive? What does that look like? Hyperreflexive. If I were hyporeflexive, what would then happen?
Nothing.
Very good. I love that for you. Remember, there's balance in everything that we do. So if one is one way, the other is the opposite of the equal to the inverse, right? Or the mirror image, if you will. Good job. Tell me about what happens when I am doing this is really okay. I can do this. When I am testing cerebellar function, what am I testing?
Brain.
That is part of the brain, yes. Is it the front part, the back part, the side part, the middle part, the bottom part? What part is it?
Back at the bottom.
The back.
If it's the back and the bottom-ish, what does the back have to do with?
Occipital.
Which means?
The
occiput. Okay, good. So then what does that have to do with? The back of the head has to deal with what part, what function? If somebody hits me in the back of the head with a club, what's going to happen?
You could lose your memory.
The lights are going to go out. If you hit me in the back of the head, the lights are going to go out. And the lights are going to go out because this ties in with vision. Okay. So if I'm checking cerebellar function, I have you shut your eyes. And if it's bad, what happens? Remember, if I shut my eyes, we're talking about needing to do what? Staying what?
Balance.
Yeah. Cool. Gotcha. All right. Now hang on to that thought. Put two and two together. All right. So what's going to happen if this person has dysregulation when I shut their eyes? If that cerebellar function is wrong, if it's not normal, what does the person do?
Sway.
Is that expected or is that unexpected?
Expected.
It's expected for you to sway. It's not expected for you to what?
Be unbalanced.
Not expected for you to fall or to deviate to one side. Okay. Is that easy enough to understand? Cerebellar function is the eyes. Eyes work with the brain to keep you balanced. If I shut my eyes and I sway a little bit, but I catch my balance, that's what I expect. That means it's working. If it doesn't and I shut my eyes, I literally fall over to one side. When we do this test and we think that someone's going to be affected, we have a person on either side ready to catch when we do this test. Is that better? Did that help?
Mm-hmm.
Okay, cool. All right. Tell me about a Glasgow coma scale.
Glasgow. What?
Glasgow coma scale. This is part of neuro.
Glasgow coma scale.
There should be on the Glasgow coma scale. If not, I can talk to you about it really quick. It's actually pretty simple. The only thing that you need to be able to do about a Glasgow coma scale is read the directions on the screen. So a Glasgow coma scale is a way for us to understand if a person is truly brain dead. It lets us know their level of cognition as well as their responsiveness to let us know if this person has potential for brain death. Okay. So what's going to happen is I might give you bullet points, and then based off of those bullet points, you will have to look at a chart. So I'll say patient appropriates this way. So patient is responsive to pain. So then you look at the chart and see responsive to pain, 1 point. You should be able to read about the patient, put the chart together, count all the points together for a final total, which lets us know how the patient's doing. Does that make sense?
Yes.
So is that different than an EEG?
So Glasgow coma scale has nothing to do with an EEG at all. An EEG is brainwave activity, which is done from a monitor with electrodes on your head. Okay. That's part of what we do, but the first set of tests that we do are the basic tests for brain death. So that is things like we put ice cold water in your ear to see if you respond. All right. That would be a sign of brain death if you don't have a response to that. Most people, that would shock the system and you would have an immediate response. If you're brain dead, the lights are out. So does that make sense? Does that help?
Yeah.
Remember, if the body is still alive, there is a disconnect between that and brainwave activity, and we would need to keep that person preserved while we are trying to take those organs and then give them to people who need them immediately. So while we're trying to coordinate all that, we have a little bit of wiggle time, and that's when we would basically take care of the physical presence of the body. All right, so let's talk about asking about mental status on a patient. How do we check a person's mental status? Give me 4 easy questions.
Oh God.
I don't agree with these questions, but for the purposes of textbook, I guess I get it, but I can debate why all these are bad ideas. But they're easy ones that we use commonly that we require. Name.
Their name, their date, where they at.
Name, today's date, what year it is, and where are you at? Name, the date. Can you tell me where you are? And what year is it? Perfect. You guys are doing great. All right, we're down to the last 5 questions. Last 5 points of contingency. In the midst of what we're going to be getting into, there's going to be 5 things that pop up that sound really familiar. We got this. All right. I have a patient who is alert and oriented. Everything's cool. They show up to me at 8 o'clock. Everything's fine. By noon, they're really, really drowsy. It's difficult to arouse them. They have a PCA pump. So my question to you is, what's the most likely explanation for the change at noon?
Too much of the narcotic in the PCA pump.
Respiratory depression.
And what happens with respiratory depression?
We need to stop the med.
What happens if I respiratory depress the patient continuous and I keep the med on? What do we retain? That is toxic to our brain.
CO2.
CO2. And what's the condition? What's the
Acidosis.
ABG? What's the ABG result that we get?
Acidosis, respiratory acidosis.
Yeah.
That's perfect. It's beautiful. Part of me wanted to go, "Ah." I love bragging on you guys so much, and everyone thinks I'm crazy when I'm like, dude, they answer questions all the time, and I literally don't say a thing. They all roll their eyes and they go, that's impossible. And I'm like, no, it's not. It's improbable. Improbable assumes that there's wiggle room, and I will always find a good use for wiggle room. We find it all the time. All right, last topic of discussion, last set of questions, and then we can all go to bed. We actually made good time. We have half an hour to spare in our 2-hour block. All right. Talk to me about prefixes and suffixes. If I tell you the word is tinnitus, give me the suffix.
Itis.
Good. What does itis stand for?
Inflammation.
Inflammation.
Good. 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 Tell me the prefix for cholecystectomy.
Colo.
Chole, okay.
Chole.
And is anyone just taking a stab at it? Does anyone know what that means?
Colon.
Cool. So cholecystectomy is actually gallbladder. And what does ectomy imply?
Removal of.
Removal of. Very good. Very good. Removal of. And is that the prefix of this or the suffix of cholecystectomy?
Suffix.
Suffix.
Yes. And then let's do it one more time just for clarification. Prostatectomy. Prefix is what?
Prostate.
And ectomy means what?
Removal.
All right. Listen. Math, we've gone over it in lab. If we need a recap on a really, really hard problem, I will give you guys the first 10 minutes of class to ask me questions, and only questions, as if I am training you guys. We're going to flip scripts. I'm going to hang up, and then I'm going to immediately see if I can get this downloaded and posted so you can look over it. Tomorrow's
Thanks, Professor Molly.
Everything's going to be fine. I love you. I'm proud of you. Take a deep breath. Enjoy the space. Know that the taste is good. Know that the air is clean. Know that I'm always going to be here with you. I'm always going to take care of you. And I am going to be up tonight working on some things for you guys. Okay. So go to bed, rest your head. And yeah, it's going to be cool. I'll see you tomorrow. Okay.
Thank you. Bye.
Thank you. Good night.
Thank you.
Thank
It
you.
was so bad.